Hi, welcome to another episode of SLP's Wine and Cheese. I'm Deb, and today I am joined by Miss Allison Fors. Hi, Allison.
Hi.
So we are going to talk today about VPI, which is velopharyngeal insufficiency. I was like, don't mess that up. People are going to think you don't know.
I know. Like, how do you say that word?
Yeah.
Well, I'm like, do you say pharyngeal or pharyngeal? I feel like both ways are correct, right?
Oh, I say pharyngeal. Pharyngeal was not even
I was like,
on my.
But it's a long word, so we're just gonna say VPI to avoid all of that.
VPI, like VIP, but not. So Allison, just under a year ago, probably over a year by the time that this episode airs, gave birth to a beautiful baby girl who had a cleft palate. So she has now taken a deep dive into the world of VPI. Can you bring us up to speed on that?
Yeah, I mean, basically, I feel like knowing all that cleft stuff, like resonance, voice, like that type of stuff, you kind of have like a superficial knowledge of it. So I've definitely been kind of like crazy mom reading up on everything. Mostly, I mean, it's also interesting to me.
Yes.
But then, you know, like with my daughter, I want to know all the things as well. And I'm also in these mom Facebook groups where everything gets brought up. Like, oh, my kid has to have this other surgery, this like P-flap, like what is this? They are saying like VPD or like VPI, like what is that? And so you see it.
So that would be dysfunction with the D?
Yeah, dysfunction. That's more of like an umbrella, like generic term for like all resonance disorders.
Mm-hmm.
Yeah. So anyways, I've done this like,
and I feel like as a speech pathologist, what you learn in school is like you hear VPI and you're like, oh, I'm not allowed to do anything because there's nothing that I can do that's going to help this child without any type of intervention or surgery. So what's your feedback there?
Yeah, so that is this question I've been getting from some people, like, how do I know if it's VPI and when do I refer? Because that is the big, as an SLP, it's your job to determine, is it VPI or like a different speech disorder?
Right.
So that is like the part of like the confusing thing for people. So yeah, like you said, if you think it's VPI, you need to refer that out. Like that kid should not be in speech therapy. There's an anatomical whatever happening.
Right.
Like all the speech therapy in the world is not going to fix that.
Right.
But in terms of like,
wouldn't they be beneficial to expose them to auditorily and visually and to sounds and
yeah, except if they have VPI, they're not going to be able to do it accurately.
Right. They're not going
to be able to. It's just probably just going to frustrate them. But once they have their surgery, like once they go to ENT and get scoped and like, oh yes, something's actually happening here, like the velum isn't closing off, get them into surgery, then they will probably need speech just to learn, like there might be compensatory errors that have been occurring. Like they kind of need to relearn that motor planning.
Right.
So they should, after surgery, come to speech therapy. Okay, where are they at now that like, you know, this has been fixed, and to help them. But in terms of like, let's say you get a kid on your caseload, repaired cleft palate, they sound nasally, like what is going on with this kid? What do I do? Is there VPI? Is there not?
Right.
You need to be running an Artic test. Because like we said, like compensatory errors are happening, and a
compensatory error is something that, just for anybody who might not know if they're listening, that's something that they did to like make up for the deficit while they were trying to speak and didn't have surgery yet. So like they just figured out a way to make a sound that was a struggle for them. So they're not using the correct resonance or placement or voicing because they found some sort of trick to get that job done.
Right. So like a lot of times how that's like demonstrating itself with with VPI is glottal stops or pharyngeal stops, pharyngeal fricatives. So if like those things are happening, odds are it's a compensatory error.
Can you give examples of those? I can't do that off the top of my head.
So I mean the glottal stops are, you know, like when you think of like like what are some examples, like the butt, or like the kind of like back here, which I guess they can't see, but like in their throat. And like I hear my daughter do that sometimes too.
Really?
Because,
okay.
Yeah, she does like some of these grunts and growls and an occasional like glottal. It's not more as common, but like I kind of hear her in the back stopping the air.
Okay.
She can't make any like those common sounds you hear in babies babbling, like the G's and stuff. Like she can't do that.
Right. Yeah.
So sometimes I hear that, but the other examples, pharyngeal stops, fricatives. So again, like they can't make the K and G, so they're substituting for like the F, S,
right,
things like that, like sounds that they can make.
Right. Yeah.
Yeah. So yeah, running an articulation test, seeing where the errors are lying, like listening for those compensatory errors and if that's occurring or if it's not. And then also testing, like doing an informal assessment or screener for resonance in general, which some people are like, well, what do I do for that? And
yeah,
honestly, just go get a screener off the internet. And
okay.
Unless this is like your thing, I would just go get a screener and run through it. I know that Christy Knickerbocker has one in her TPT store that's pretty thorough.
Okay.
I also know that there's a website called Leaders Project, and it's amazing. It has so much cleft palate info, and they have a screener on there. It's not as thorough, but it's it's good just to have on hand anyways.
Right.
I think Asha has like a speech sampling thing as well. So I actually have this page on my website where I have those linked. It's like a cleft lip palate, like all information.
Okay, good. Yeah. So go to Allison's website. Is it AllisonFors.com?
It's AllisonFors.com, and then it's / I think it's cleft lip and palate. So you'll find the screeners linked in there. So yeah, get a screener. Like run through it. It's going to have you do different, like having them prolong vowels and seeing what's happening. If there's any nasal air emission, like if you hear it nasally or not, it's going to have you run through doing things like pa pa pa. Like those repetitions, counting to see, you're basically listening for if they're nasally or not, if there's any nasal air emission happening, hypernasality. There's other resonance disorders, but those are the ones that come up with cleft.
Okay.
As opposed to like hyponasality or the cul-de-sac resonance.
Right. So you're listening for hypernasality. Are you also listening for like inefficiency, like unable to build up pressure and maintain airflow to produce these like sequential tasks?
So especially with hypernasality, those voiced consonants are going to sound weak, like muffled.
Okay.
Because they're part of that air is coming out of the nose. So they're not going to sound as strong. Like you think about like P, like that plosive, like it's not going to, it's going to sound weak. And nasal air emission is going to sound almost like too loud. It's going to, so, okay, let's back up a second. So in kind of assessing this, to be able to hear the differences in those resonance and like the loudness or the weakness of it, some people use straws or other devices to be able to amplify that sound coming out of the nasal cavity or the oral cavity so they can hear better. So I know some people use straws, like that's kind of the, you have straws on hand. There are like more expensive, like
versions
unquote,
of
like
straws,
better options. Okay. Like I know Super Duper has one. It looks like a stethoscope for you and a stethoscope for the kid, and it's attached by a tube, so the stethoscopes are attached together. And then there's a branching tube, and that's for the child to either how about the nasal cavity, oral cavity, so you can hear better. And so what makes that one cool is both the child and you can listen at the same time.
To the same sound.
Otherwise, like there's other devices out there where only the kid can hear, or like,
what an intricate device that I'm trying because I don't have the visual.
Super weird. It's like two stethoscopes connected with this like branching off tube.
Right.
But yeah, that's what can kind of help you in determining Like in hearing that better, I guess.
Okay.
Hearing what's happening.
So you did all these little assessments and you're determined that this child can build up enough pressure and they are hypernasaled. I need to refer out.
Yes. Yeah. So if you basically it comes down to, is it the compensatory error where we're doing articulation therapy, or is it a structural thing with the VPI and we need to send them off to ENT?
Right. So I've had 2 experiences, and I don't expect you to have this answer, just this year, so my first one was I have a CF who had a kid with a lot of different speech sound distortions and errors. And then she said that she thinks that they should get seen by an ENT. The ENT wrote in the report that maybe speech, like diagnosed VPI, and then said speech therapy may be able to prevent surgery. And I've never seen this or heard this ever. And I think that's quite odd.
That sounds odd to me.
Yes, I think so too. Okay.
Because the speech therapy can't elongate the velum.
No. So it's like, did you really diagnose that? Or are you just so unaware of what speech therapy can do? Or because I read the report and it said these things. I was quite surprised. So then my advice in that example was to refer out again to somebody
like, let's try a different ENT.
Yes. Somebody else, because I don't know about that. And then my next one, so I have a child who just really struggles in terms of oral motor, just struggling to copy any lingual movements. I finally got him to elevate his tongue, and I see tongue tie, and it's not the worst tongue tie I've ever seen, but I see it there. So then I tell the parent, refer to ENT, and the ENT says that they think it's psychosomatic and that there's no structural issue. But I'm like, but the tongue is still not coming up. So are you sure? So again, my experience is to refer again, because I'm just not in agreement or sure. You're working with a whole cleft palate and craniofacial team. So you're working with people who really are knowing what they're talking about. ENTs do a lot of stuff.
Fortunately, with your kid as a cleft, then you're on the craniofacial team.
Yeah.
All of those, the orthodontist and the dentist, the ENT, and all the speech therapists, all these people are knowledgeable in that realm.
Yeah.
So ideally, it's not hard to get appointments. It's not hard to get a diagnosis. It's not hard to get the procedures you need done.
Yeah.
Ideally, right? Because if this was happening with my daughter, I'd be calling up the craniofacial coordinator. I've done this already.
Right. Yeah.
I'm like, hey, we need to talk. And I get an appointment right away. And the surgeons, they're awesome. And that's what's cool is you see these people over and over again throughout the years.
Right.
You know them, they know you, they know your kid.
And they monitor. So after the surgery, they monitor the progress to ensure that speech has gone to achieve typical.
Yes.
Because that is the goal.
That's the goal. I believe the craniofacial SLP said our first visit with her post cleft repair is 4 months after.
Okay.
Where she can just kind of assess, we see where she's at, what's going on.
Right.
So there are definite time. It's a timeline of when appointments occur for various people on the team.
Right. Because I had one child with a repaired cleft palate. So I hadn't seen them until I was their second therapist. So I hadn't seen them till a year after they had been repaired. And the issue there then is that if the speech is not achieved typical by then they have to start talking about what is the problem. Do they need a palate expander, or do they need to go back in and do surgery again? So that's why it's essential that the speech therapy that you're conducting is is having improved speech. So apparently the therapist prior to me was doing a lot of whistles and oral motor stuff that was not evidence-based. So Yeah. So that was not helping. And that was like detrimental to this child, not just like in terms of speech sound production, but also like, you know, them determining if he was going to need to get another procedure, which is pretty major. Right. So in all of the things I said, I think it's super important to choose who you're referring out to. So I don't have a person. This is advice that I'm just coming off the top of my head, because like when I have gone to parents and I have just said, I think this child needs to see an ENT, I don't have an ENT in my pocket to be like, check out this person. And then they often go to their own, and it's been like 2 or 3 times now where the ENT has come back, said like, oh no, they're fine, where I don't think that they are. And then you're working with a whole team of people who are constantly confronted with VPI and all of these craniofacial issues. So they're going to be more knowledgeable. So it's quite important to, I don't know, not just take any opinion that, or any result that you hear.
Yeah, I mean, that's interesting, because if those kids were cleft affected, you'd think that it would be the craniofacial ENT who they're seeing. I mean, you'd hope, right?
Right, but I honestly don't. I don't know.
I know. But yeah, you made a good point that I want to come back around to.
Yeah.
Oral motor exercises, like, no.
Don't
do those. You're just going to waste your time. Like, that's not, yeah. And I feel like, I mean, I think it's getting like more out there, like the word's getting more out there, but that just does not, you're just wasting time and like the kid and all of that stuff. But another thing to do when you're like looking at these kids and you're screening them and figuring out what's going on, you really need to do that like oral exam, like you were talking about.
Right.
Looking, like you have to be looking in their mouth, looking at their palate.
Right.
So looking at their palate for fistulas, which are holes. So I think it's like, it's kind of a high, I don't remember the percentage, but it's kind of high how many fistulas occur after cleft repair.
Oh, okay.
So if there's a hole in the palate, like obviously there's going to be a resonance issue. They need to go to ENT.
Right.
Looking for a submucous cleft.
Right.
Sometimes that can take a while to get diagnosed.
And that's hard to see, because that's like a hole that's covered by tissue. So it's not something that you're able to,
And that's why it can take a while. So it's like, the soft palate isn't there, but there's tissue. So the palate looks intact, but really there isn't a soft palate. And so how you can screen for that is have the kid open their mouth, stick their tongue out and like say, ah. And if the palate goes up into a tent shape, that's a good indication. Or if their palate looks bluish in color, like thinnish bluish, that's a good indication. And sometimes the uvula is different, like it's square or bifid.
Okay.
That's also an indication of a submucous
Interesting.
cleft.
Yeah. So I haven't known those. I saw something, I think it was on the Informed SLP TikTok, if I'm not mistaken. And somebody said that if the child could stick out their tongue and then blow air in their cheeks, then that's indicative of a good seal. And if they can't, then there could be a fistula or submucosal.
Okay, I think I saw that too. And this is like ringing a bell for me.
All right, okay.
Yes, I mean, I guess that is a good test. Like, I hadn't thought of that. Yeah, that they can, because then there's a seal happening there where they can blow up their cheeks like a balloon, and there's not air leaking.
Yeah. And you just look like a freak too. So it's coordination. And then going back, so the oral facial exam, Amy Graham has a great one. So that was good. And then also I have my handy dandy throat scope here.
Oh, yes.
Which I use on myself all the time because I'm strictly virtual now that I am 35 weeks pregnant today. I'll be 36 soon. But this is going to be dated, so I probably have a baby by the time you guys are listening. I hope the future is going well, people of the future. I hope you're washing your hands and getting vaccinated.
That's right.
But yeah, so I think that just like our last episode, while we're wrapping up this topic, I know we want to talk a little bit about treating hypernasality, right? Is that what we want? Oh, yeah, targeting hypernasality.
I mean, if we have time.
Yeah. So we'll do, so first let's talk about, so what you can get, because what we can get to help us be better. So you said, go to your website because you have links to residence tests or screeners.
Yeah, like screeners, things to go through to help you determine if there's a resonance issue happening and what that resonance issue is.
And then also, and then checking out Christy Knickerbocker, her store. She's Christy Voice on Instagram, and she's got resources. And then also Amy Graham's oral facial exam and a throat scope. And Allison said, I think I've used straws a ton in speech. And there could be more expensive straws, but maybe a straw is good.
Yeah, I'd say try the straw. And then if you need something else, go get it. But yeah. And that leadersproject.com website's awesome.
Oh, yes.
So bookmark that for your little cleft, in the future, if you get a kid, that's a good website to have access to.
So then now we know we have a kid with hypernasality, and it's not VPI in the sense where we can't target it. What can we do to work on the hypernasality?
Yeah, so this hypernasality, they can have the closure, their velum is long enough, but for some reason the air is still leaking through, mostly just because they haven't had to make that oral movement before.
Right. Or maybe sensorily, kids, maybe they just, I don't know, they like it there.
I do think some kids, even after their, VPI repair, they need to come to speech therapy just to learn the difference. Because with hypernasality, it really comes down to ear training them to where they can understand the difference between oral air and nasal air. Right. Where is this air coming from? So this, what we're talking about, the straw.
Yeah, I think that's important too. Just oral, facial, nasal proprioception.
Yes, them understanding the difference.
Yeah. What that sounds what are you even talking about, lady? What? Why? Yeah.
And that's really what the therapy is.
Yes.
Differentiating that and having them able to self-monitor and distinguish. So with the straw, what you're going to do is have them a sound that they can do great, where it's not nasalized, an S or something. Have them use their straw, put, in their mouth to the ear, make their S, you hear that, right? Yes, that's a strong S sound. You hear that, it's coming out of your mouth. Now put it to your nose and your ear. Okay, did you hear anything come out? No, there's no air coming out of your nose. So that's the S is a mouth sound, and going through all the stuff, and then doing that again with a nasal.
Right.
An M or something, do the nose and the mouth. Okay, I hear that through the nose. So that's a nasal sound. And then talking about, however, whatever terminology you want to use, the oral sound, nasal sound, or mouth sound, no sound, which ones are which. Basically, nose is just MN and the N sounds, right? ING. So really laying that out for them. These are the nose sounds. These are the mouth sounds. And having them practice that and being able to self-regulate.
Right.
And also, sequencing, I wrote this down so I'd remember it, sequencing the a vowel with a nasal, and having them practice going between go and practice going from a mouth sound to a nose,
oral nasal.
Right, having them go back and forth so they can feel that difference is a next step.
Okay.
So that's targeting hypernasality, a quick run through of that.
Yeah.
I know there's more tricks to helping kids.
I would do things with touching the nose. You don't want to occlude the nose because you want the sound to come there. But I'd be look, I don't feel anything.
Yeah.
But now, I feel that buzz. So
and the buzz.
But then you still first have to do what you were saying, which would be identifying the sounds that should have a buzz and the ones that should not, so that they can discriminate between the two.
Yeah. Some other tricks that I know some people use is either trying like changing the pitch or changing the volume or how open the mouth is when you're making those sounds, because that can kind of, I don't know, I guess that can sometimes help kids. I've never personally done this, but in my reading, some people have done that to help with like it can affect how hypernasal the kid is, like how nasally the sounds are coming out.
Right, like changing the frequency, like the size of your instrument or your oral cavity.
Right.
Got it. Yeah.
But you're basically teaching new motor patterns. That's what's happening, and like bringing awareness to like the airflow, like where the air is coming from.
And I feel like
anatomy lesson too might be good for like those older kids.
Yeah, for sure. Anatomy. I feel like I do this for my RTIC kids, especially the R kids. We spend so much time on just understanding like what's in your mouth and what's supposed to be happening in your mouth. Like it's when you do yoga and the yoga teacher's like, put your back flat and your legs straight behind you, and you're like, it is, and then you look in the mirror and you're like off to the side crooked.
It's
like
true.
You don't know.
I need a mirror.
Yeah, exactly. So like I'm telling the kid to lift up their tongue and they're like, I am, but they're not, because they don't know what it means or feels like to lift their tongue up. And then I'm like, not only are we lifting up our tongue, we're lifting up our tongue body. So the back of the tongue, the part of the tongue you can't even see. That's what's got to go up. Now squeeze it, because we need tension. So just understanding like, and not to confuse these things with oral motor exercises, because it's not.
That's different. Yeah.
It's totally different, but you're increasing sensory awareness and proprioception so that you can use these things. You're not like doing it in a means. I'm not like having a kid lift up their tongue with the intention of increasing strength.
Strengthening it. Yeah. It's just awareness.
Like lift it up. That's up. This is up again. That's not up. Yeah. So this has been super eye-opening. Be sure, just to sum up, that if you are working with a child and you suspect VPI because they have some hypernasality or some weakness in some consonants or whatever the case, that you do your research and you refer out, and you make the parent at least well aware that it's important to choose a provider who has experience in this area, because they might give bad recommendations. Yeah.
It's a bit of a specialty,
for sure. Then you can also get like over specialized, like, because like I feel like if you go to a cardiologist, they're gonna be like, look, the heart, it's the problem. Or you go to neurologist, they're gonna be like, the brain, that's what's happening. And if you go to like a dentist that's known for tongue tie, they're just gonna snip everybody. So it's hard. You have to do your research and trust yourself, and also advocate for your client. It's tricky.
I mean, fortunately, scoping someone, like, that's pretty, like, whether VPI, like whether there's like a leak or not, is pretty apparent, you know?
Right. So you advocate to that. You can tell the parent, like, scope is a good way to know. So if they didn't scope, then they might not have the best information possible.
And if an auntie's not scoping when they go in for that, that's kind of a red flag.
Yeah, my first VPI kid, I was like, there's no way this kid doesn't have a submucosal cleft. And then the ENT said that they were fine. He didn't scope them because he said that there's no way that he was going to be able to be compliant and get it done. So I was like, I don't know what he based that assessment on. Then I Googled him and I was like, this ENT is too hot. So I think that he's just too attractive to be an ENT. And he just doesn't know what he's talking about.
Oh my gosh.
And I'm not trying to discriminate against hot people. I'm just saying that's what popped into my head, and I am just a human. And on that note, any final words, Allison?
I mean, just do your homework, because there's lots of research out there. So I feel like sometimes you get that kid on your caseload and you're like, wait a second, and you're racking your brain. So research it is, Google it is.
Yeah, research.
Pretty good resources out there.
Right. And then, refer again if you think you don't agree. Yeah. Well, thank you so much for joining me.
All right. Thank you.